So I'll like buy all this good stuff. And for those of you that are new to the Take a Breather Foundation, I'd like to take a quick minute and share a little bit about it with you. Matt McCluskey is the executive director. He also has Cfrd, and is 5 years post of a lung transplant. He began Take a Breather in 2012 to provide a breather in the form of a wish to those battling cystic fibrosis. Their mission is to give people with CF, along with their families, the opportunity to take a breather from the disease and focus on creating memories that will strengthen their hearts and minds as they battle the emotional and financial turmoil that accompanies life with CF. In the past, this included travel breathers like trips to Disney World, Atlantis, RV trips, or weekend getaways. As you can imagine, since the start of the pandemic, with travel and in-person meet and greets restricted, they've pivoted their mission to provide financial help with medical copays, utilities, transportation, food and rent assistance, and have also provided non-travel wishes such as laptops for at-home learning, exercise equipment, video game systems, and more to help bring them a little breather. And lastly, Take a Breather has begun holding webinars like tonight's to educate and share in-demand information with the CF community, as well as raise awareness about CF. In short, they're an amazing group of people who do so many great things for those living with CF, and I'm thrilled to be involved with them. I'd also like to take a quick minute to thank tonight's sponsors for helping to make tonight's event possible. So a big thank you to Vertex, Beatrice, Gilead Science, and Nestle Health Science. Thank you so much. Okay. There's a few housekeeping announcements that I have to go over. Tonight's webinar is for informational purposes only. Medical information discussed is general knowledge for the CF community as a whole. Just like CF, CFRD is a very individualized disease process. Sorry about that. So for case-specific questions, please consult with your personal CF care team and your endocrinologist. Personal medical questions cannot be answered here. This webinar is being recorded and will be available tomorrow on our on the video page of our website, which is www.takeabreatherfromcf.org. Also, we have a live Q&A portion tonight, so you can ask questions directly by using the Q&A icon on your screen. You can start to submit your questions at any time, and we will surely try to get to as many as we can within tonight's time constraint. Okay, so the housekeeping is done. Let's get on with the good stuff. Without further ado, I'd like to introduce our very special guest, Kat Quinn Porco, I'm sorry, Kat, who is a certified diabetic educator, founder of the Attain Health Foundation, and mom of 2 children, one of whom has CF and CFRD. So thank you for being here tonight, Kat. We really appreciate it.
Thank you so much for having me.
Yeah.
It's an honor. So
thanks. Good.
Yeah.
I'm super excited to be having this discussion with you tonight. CFRD is such an important topic and also a huge topic. Not only is it a second time-consuming and extensive disease process for us to manage on top of our CF, but it can also directly affect our CF health. I know we will barely scratch the surface tonight with all there is to know about CFRD in the hour, but the hope is that people listening may hear something new and could help them.
Absolutely.
You know, there is no one else I'd rather talk to about this than you. You not only have the education and knowledge base, but you're a part of the CF community yourself, living every day with this on a very personal level. So you truly understand. And in my opinion, your passion is unmatched. Seeing an unmet need for your child and working to help create a solution from someone living with CF and a parent myself. You're such an inspiration to me, and I am just in awe of you, and so lucky to now call you friend. So with that, I'm going to turn it over now to Kat, and in a bit, we'll open it up to the Q&A.
Awesome. Thank you so much for the kind introduction, Jen. Well, perfect. I will just echo, well, first of all, thank everyone for coming, and thank Jen and Take a Breather for offering this opportunity to get a little more info out there about CFRD. And I'd like to just echo what Jen said. I totally understand that there are going to be a lot of questions that are very personal for you, and I will do my best to answer them in a way that's cautious of how nuanced this really is, and that an answer for one person definitely isn't for another. So if you have questions after this, please talk with your team. All right, so I will share my PowerPoint here. Okay, so we're just going to start with a quick kind of overview on the CFRD kind of management and how to change the feeling of being out of control into being educated and ready to take on CFRD is really always the goal. So, so first of all, I would like to reintroduce myself. Yes, I am a mom to a kiddo who is 15 with CF and CFRD. He was diagnosed at 10. So we're 5 years into kind of the personal journey. And then I also get to be a certified diabetes educator to the best clients. And just for those of you wondering kind of what my background is, there's a quick snapshot of kind of the process that I've wandered through in my CF journey. So what are, I guess, understanding the why is the most important part of CFRD management. And that really, for me, working with people is helping them to have the innate motivation to understand and to be their own advocate. So why is managing diabetes important? Because it protects your pulmonary health. And whether you are pre-transplant or post-transplant, it is critical to minimize the sugar that is in your lungs. So we do that by keeping tight constraints on our blood sugar. As we are entering this really exciting time of modulators, people are living longer. We, at this point, don't have a lot of data on long-term complications that we see in type 1 and type 2, such as neuropathy and eye disease and kidney disease. But we believe those are probably coming. It's just that the data that we've had up to this point has been shortened. And so that's another consideration, of course, as we're looking at why we're trying to manage CFRD more aggressively. And then, of course, just feeling better and having more energy. We know that people prior to a diagnosis are often complaining of fatigue and just not having good energy or sleeping a lot or what have you. And oftentimes, once we get diabetes under control, they see that those symptoms really do are mitigated quite a bit. In fact, I've had a number of people that have said, oh, I thought I was so tired because I have CF, but it's actually untreated CFRD. So just kind of keeping that in your mind if you're one of those people that knows that your diabetes is maybe not as tight as you want it to be, that there's hope that this will actually really impact your overall health as well. So I work remotely, of course, but I do partner with care teams to try to get the best outcomes for you guys, as you are the experts in your own lives and you guys are the ones managing this day in and day out. And so I try to understand your life. I try to understand all the nuances that you are managing and try to and the goal that you want in the end. Not everybody wants extremely tight blood sugar control, and that's totally fine. It's whatever your goal is, and then we make those steps to get you there. But also just knowing that like this is a team approach because I'm not a part of a care center. And so when I partner with someone, I then also work with the team and help to make recommendations if you're in the hospital, create sick plans, things like that, help you to understand other resources that are available to you as you manage this disease. So I'm a huge fan of technology. I feel like it's out there for us, whether you have a CGM, just to kind of understand. I think it's just an incredible tool. We often, we hear, oh, test your blood sugar 2 hours after eating. And at 2 hours after eating, your blood sugar should be pretty close to normal. It's the 1 hour mark. And so having those CGMs that can really show you what you're doing postprandially is just an incredible benefit to not only you, to understanding like a need for increase in insulin or decrease, but also to understand timing and to just really be able to titrate your insulin so that you're covering those carbohydrates. The pumps are incredible. I don't think I've had anyone that I've started on one that said that they wish that they wouldn't have. I think everybody kind of just says, I wish I would have done it sooner. So pumps are an amazing asset to diabetes management. Definitely something to think about in CF. I know you're, connected to IVs, you're connected to feeding tubes, you're connected. So that is something to think about, but it does enable you to have a lot tighter control. And then of course we kind of have the hybrid system, which is the InPen. And that is kind of just a way in which to really track what you're doing and how you're responding and loop that in with the Dexcom so that you have really good data. And moving on from technology, another thing that I just really always want to emphasize is stacking. And so many people stack. And that is where the InPen comes in as an amazing technology, is that it helps you to calculate what insulin is on board and the carbohydrates that you're about to consume and how to titrate that insulin so that you're not overdosing. So when someone comes to me and they're chronically having extreme lows and extreme highs, it's generally because of stacking, like 9 times out of 10. We can walk through the day and be like, oh, so you dosed insulin at breakfast, you dosed it at your 10 o'clock snack, your 11 o'clock snack, and at noon. You are absolutely going to have too much insulin on board if you're dosing for the exact amount of carbohydrates. We have to take into account that there's still insulin on board when you dose that. So just really keeping in mind the importance of understanding insulin duration and insulin action so that you can avoid those lows as much as possible. Anybody that's worked with me knows how much I hate lows. And then the common pitfalls: prime your pen, 2 units every single time, because as many of you know, every once in a while you'll get a pen tip that just doesn't work. And if you don't prime it, you don't know that. And that pen tip has, if you prime a unit, you see that one tiny drop comes out. So if that one drop is what's making it into the pen tip, you're always going to get less than your actual dose because the insulin needs to get to the top of the pen tip before you make the dose. And on that mark, new pen tip every single time. I know we all hate that, but it is, insulin is very viscous, and especially if it sits there for a little bit. So you're never assured that you got the full dose if you use the pen tip more than once. And bacterial concerns. It's really kind of gross. And then, so bolus insulin expires at 28 days, not 29 days, not 30 days, 28 days. And by the time it hits 29 days, it's almost water. So if you're using a pen until it's gone and having very small microdoses of insulin, if it's beyond that 28 days, you are not getting any insulin. So I always like to encourage people to use a Sharpie and write the date that they're going to throw it away. So count on the calendar, write the date, and know that you're going to toss it out. The InPen keeps track of that for you. So if you have the InPen, you won't need that. But either way, it's just very important to think about that. And most basals are the same except for Tresiba, which is, I believe it's 38 days. But that's all in the packing information or online easily. But yes, so definitely keep track of what day you opened your insulin. And then we already kind of talked about the timing of insulin, but as far as that, the InPen is an amazing resource to get that figured out. Remembering that if you take it too early, you will most likely see a low and then a high later, because the insulin's working before the food is being digested. And if you take it too late, you're going to see a huge spike and then probably a drop and then potentially a very severe drop as your phase 2 insulin kicks in. And then just rotate dosing sites. It's just really important. We create scar tissue in places where we continually dose insulin. So if you ever feel like a hardening or a raised area or even an indentation, you just want to be really sure to let that space have like 30 days to heal, because you cannot, the insulin will actually go into the scar tissue and then it doesn't disseminate as well into the rest of your body. And so you will have, the wrong dose for what you're eating. So I think that, my program has definitely been based around the idea of self-reliance and empowerment, and just really understanding that your goals are the only ones that are going to be achievable. Coming to clinic and having a dietitian or a CDE or an endocrinologist say, this is where I want you, isn't going to be successful. And it has to be something that you understand why you're doing it and that it has the value that allows you to really commit to it. So just some quick tips on carb counting. Yes, scales are amazing, cups are amazing to practice with, but we also know that long-term that's really not, it's just not feasible for normal life. So I really encourage people to start guesstimating and keeping track. Again, the InPen, it's amazing. And that helps you to confirm like if your carb to insulin ratio is correct. It also helps to, make sure that all the settings are right and that you're making that calculation correctly. But yeah, just really kind of seeing this as an opportunity to refine your skills of guesstimation, because most people don't have a whole list in the back of their head of how many grams of carbs, a third of a cup of rice is. So just like understanding when you look at a bowl of rice, like knowing what a third of a cup actually looks like, it's usually a lot less than we want to think it is. And if you have a child, I love having like a photo book that has like things that they eat regularly with the amount of carbohydrates next to it, just so that they can start taking some responsibility. Like if you're thinking of being 18 and going off to college and having all this, like it's really good to be empowered when you do that. And then there are a lot of apps that are coming out like BiteSnap, and there's 3 or 4 now that are actually estimating the carbohydrates. Definitely use your thinking skills on that, but to double check, but there are a number of them that are actually pretty accurate. And then insulin dosing, there is a really great dosing chart on the Attain Health website, and you can put in your or your child's carb to insulin ratio, ideal blood sugars, and then print it out so that you have it. And if you're if you're having like 50 grams, you just go to the chart and it tells you like if you're below 100 to pull back a little bit on the insulin, and if you're over 200, increase that. So it's a really helpful cheat sheet to have around. And then I think it's just so important to remember to test, to know what your blood sugar is prior to eating or dosing actually, and then eat and then test again to make sure that you really understand how your body is utilizing that insulin. And if you're looking for more support, if this is like, okay, great, little bit of information, I definitely need more. We do have a self-paced program at Attain Health Foundation. We tried to make it as cost effective as we can. It's $50. It's 12 modules, and all of the videos are done either by Dr. Colleen Wood, who's a CF endocrinologist, and or myself, or Jordan Robson, who is a CF, well, she's a dietitian, but also has CF, and she does the one on nutrition and CFRD. But this will be living on the Thinkific website for a while, and then I think we'll switch it over to to another website, but for now it'll be there. And it really is a really robust program if you're looking to learn more. And yeah, you guys anybody is more than welcome to check out our coaching website as well if you're looking for more one-on-one education and support. But otherwise, the self-paced program is there for you to absorb all the information that we've collected over the last 5 years. So that is the end of my presentation. Jen, we can go into Q&A if that works.
Yeah, thank you so much.
Yeah.
It's funny, even when I, hear you talk again, it's been a while for me, but there's always like a tidbit of information or a nice reminder. You can't ever hear it too much, really.
Oh, I thought you were going to say it makes me want to fall asleep.
No, please. Everything you said is like ringing bells in my head, even like, so glad I got the pump. Wish I got this years earlier, yeah. all pertains to me. Yes, it sounds familiar. Okay, so we have a couple of questions building up in the chat. Feel free to use in the Q&A icon. We had received some pre-submitted questions, so I'm going to start with those. Let's see. Can you expand on the oral glucose tolerance test, how it is used to diagnose CFRD and its accuracy?
Absolutely. So the OGTT is a great tool for understanding dysglycemia, for sure. It is, so we're taking a fasting and then giving a really, really high load of glucose, usually 75 grams of glucose that are simple sugars, meaning it's going to be ready right away. And then we're seeing how much activity the pancreas is able to offer us, right? So in CF, we see that it is often falsely, reassuring, and that often the clinic is only testing the 2-hour blood sugar. And as I said earlier, at 2 hours, most people, unless you have delayed gastric emptying, their high blood sugar will resolve. So it will show that you have a pretty normal blood sugar, maybe a little elevated, like maybe 180, but nothing that would cause a diagnosis. So it's really imperative if you have an OGTT or your child does, that you absolutely ask for that 1-hour OGTT test, which often they're a little hesitant about, but it's really important because what we're trying to see with CF is very different than what other types of diabetes are trying to see. So we're trying to see that it always stays under, 140 ideally, but 200, so that the damage to the lungs is less. So a diagnosis for CFRD would happen much more closely to a diagnosis for gestational diabetes than it does for type 1 or type
2. Okay. It's funny you mentioned gastroparesis because that was the next question. It just said, what is gastroparesis and how does it affect blood sugar?
So gastroparesis, obviously being kind of the more severe form of delayed gastric emptying kind of idea in how it impacts diabetes, but it's just a very, very slow processing of carbohydrates. So with individuals who I work with that have severely delayed gastric emptying or gastroparesis, we'll see the high instead of at the 1-hour mark, at the 4-hour mark, or the 5-hour mark, or the 6-hour mark. So it's really challenging to match insulin to carbohydrates without a pump in that situation. So
going through so slow.
Yes, exactly. Okay. Mm-hmm. Yeah, it just doesn't break down nearly as quickly.
The next question was, I'm starting to train for a marathon and wondering where I can find some resources for distance running and running nutrition information for people with CFRD. Also, are there any specific things to be aware of with running nutrition and CFRD?
Yeah, absolutely. So I'm not sure of any like direct resources that would cover all three of those other than talking with Mike and I together. But I would say that as far as exercising, you want to think of every 30 minutes, you need 15 grams of carbohydrates. So prior to exercise, I would take 15 grams of carbohydrates, and then I would plan every half an hour to take another 15 grams in order to keep your blood sugar stable, because that's about what we see for dropping. That being said, if you're doing strength training, you will see the opposite. So anaerobic and aerobic. My husband's yelling from the other room. Aerobic and
Thank
anaerobic.
you, Mike.
So yeah, exactly. Thanks, Mike. That, you know, your blood sugar will actually rise with things like lifting weights and more sedentary exercise, for lack of a better term. But like anytime you're engaging the muscles, you're going to see an increase versus a decrease. There are some people who do see a decrease with strength training, but it's usually that's more tied to people who are closer to being type 2 diabetics, who have more inflammation.
Thank you. You mentioned quickly, I don't know if there was anything to expand on, but we did have a question that, are there any apps available for carb counting for beginners in general, and like that include when you're out to eat?
Yeah, I mean, so Bite Snap is, yeah, definitely a good one. And the Calorie King app has an unbelievable, expansive library of restaurant foods and all of that to at least get a number there. Yeah. But again, like the InPen is great for that as well, because it has a database in that too.
Oh, I didn't know that. Okay. Next question is, does everyone with CF eventually get CFRD, and does the CF diet of high fat, eat anything you want, high calorie, cause CFRD?
So CFRD is not a dietary, it's not related to any diet choices. So what happens is that the enzymes that are released out of your pancreas don't go anywhere, and so they die on the outside of the pancreas, and that actually kills the beta cells. And the thick mucus and all of that just makes it really difficult for the insulin to release from the pancreas. That being said, type 2 diabetes is not unheard of in CF, and so you can have CFRD and have type 2 diabetes, and that can be based on diet and exercise and genetics, absolutely. So with that, we would just see a much higher level of resistance in people, so they'd be on much higher doses of insulin than the average person with CFRD who still makes some insulin.
Okay, next, this is the last pre-submitted question we had, and then I'll go over to the live ones. Why is there weight loss associated with CFRD?
Yeah, so in people with diabetes, insufficient insulin prevents the body from getting glucose from the blood into the body's cells to use as energy. And so when this happens, the body starts to burn fat and muscle for energy. So it just creates a reduction in overall body weight because of that lack of insulin to utilize the energy.
Okay. All right, let's see what's happening in our live Q&A. Let's see. Okay, if you're borderline for CFRD, does having a low carb, low sugar diet slow down the progression?
So those of you that have been through my program out there know that I do not believe in borderline. I believe that there are stages to CFRD. There are 4 stages, and borderline is stage 1. It really isn't. It's really the time in which, you know, you've lost the first phase of insulin, and you're seeing either, you know, it can go many ways, but it depends on, I guess, what stage you really catch it at. But You can just be seeing like hypoglycemia. You can be seeing that you're waking up with a fasting blood sugar above 120. But we go over that in the program, and it's very broken into 4 stages, and that anytime there's dysglycemia, that it's a stage of CFRD. There's no saving the pancreas as far as that's concerned. The thing I will say about that is that even when you're borderline, your pancreas is working insanely hard to break down all the glucose and utilize that appropriately. I mean, utilize the glucose. And so we have found that having a very low dose insulin early on, some people that don't even have a diagnosis yet, that their pancreases are able to stay at that stage 1 much longer, just because they're not overworked.
Should people with CFRD be on a low carb, including sugars, high fiber, and high protein diet?
So I am not at liberty to answer like specific nutrition questions. As far as diabetes is concerned, which is the only certification I have, I believe in moderation and feeding your body to feel good. And so I think that the idea of, there's a lot of people out there that are going to tell you that a keto diet is fantastic. The research is not there for that. It is there for people who have seizures, not for diabetes. And so I would be very cautious with that, because glucose is an incredibly important, or carbohydrates are extremely important energy for our brains and the rest of our body. So it's very important to kind of think about that balance and what that diet was actually created for.
Thanks. Let's see. I am new to this area of CF. In general, what are the greatest challenges with managing CFRD and CF? That's a big question.
It is a big question. And it's very cyclical, because I feel like if your CF is challenging, your diabetes is going to be more challenging. And if your diabetes is challenging, your CF is going to be more challenging. So I think just diving in, like, I think that most of the people that I've worked with, it's the fear. It's, you don't know what you don't know, but when you don't know, you feel more apprehensive and anxious and fearful. And so I think recognizing that, knowing that there are ways to manage diabetes, even though it feels big, and really just kind of bringing it into your life rather than trying to push it away or ignore it, because it will come back. Even if you don't feel the complications now, it's working in the body just the way CF is, even when you feel good. So.
Okay, I've never heard of blood sugar affecting the lungs. Can you explain the connection, please?
Yeah, so we can take tissue from the lungs and test it for glucose, and we're able to test it in the lungs at 140. So anytime your blood sugar is above 140, sugar is diffusing into your lungs. Sugar creates very viscous environment. It also is a fantastic nutrient for bacteria. And so, and it does direct damage to the lung tissue. So it's an ugly fact that we have to face, but they've done lots of studies, and that is diffusing at that point. So so we just want to keep it under 140 as much as we possibly can to protect the lungs.
I remember when I took the Attain program, that was like the one thing that like blew my mind. I was like, whoa, I better get a handle on this real quick.
I know.
Because I knew I was way above that number the majority of the time.
Yeah. And I think, the ADA recommendations are 180, but that is to minimize long-term complications. microvascular complications. And this is simply to protect the lung health, and very important in post-transplant too, for those individuals who are post-transplant. It really increases the risk of rejection.
Let's see here. Can you elaborate on what an in-pen is?
Yeah, so it's an app-based pen that's Bluetoothed to your phone, and you actually just get cartridges every month to put into the pen. And this is only for fast-acting. You would still need your long-acting pen, but you actually input your carb to insulin ratio, and you can change it throughout the day. So you have, I mean, a lot of, especially females, have higher doses in the morning than they do at night, just based on hormones. But then all you need to do is count your carbohydrates and input that, and it takes into account your Dexcom number, and then it gives you the titration that you need. It will also it keeps track of how much insulin is on board based on how many doses you've given in the last 4 hours, and will also titrate for that, and or if you're above 200 or below 100 or whatever your parameters are. So it's an incredible technology for individuals who are living with diabetes, but it's like just absolutely the best tool that we have working with you to be able to understand your titrations and carb to insulin ratios and timing, and how we can help you with pitfalls. It's just an incredible map that we can look at that shows exactly when you dose, how high you go, when you drop down. And so we can get this incredible picture to really help to bring your management into tighter parameters.
It's really super cool.
I know, I wish they had it.
Yeah, no, that was something new after that.
Yeah.
Let's see. I do realize after you said hormones for females, I had skipped a pre-submitted question, so I just want to jump back to it so I don't forget. What causes blood sugar fluctuations in the middle of the night when you are sleeping and not eating, whether it's spiking or dropping low at certain times?
Oh, great question. So generally there's two main things that cause those, either highs or lows. So if you're having a low in the middle of the night and you haven't dosed in hours and you do not have delayed gastric emptying, we would absolutely look at if your basal was too high. Anytime that's outside that 4-hour window, if you start to see it decline, then you know that you have too much basal on board, because the only job of basal is to cover hepatic glucose and keep you steady, and bolus insulin is there to cover all the meals. So the other options are the Simoji effect, which is so much insulin. So taking too many doses at night before you go to bed will often have a low, like around kind of 2 o'clock, and then a spike up after that. And the other is the dawn effect. And the dawn effect is really just hormones. And so we'll start to see usually around 3 or 4, just start to kind of climb until you get up in the morning. And if that's the case, then you just don't have enough basal, or you're taking basal at, if you're taking Lantus and it's waning over those last 4 hours, then we often ask people to switch their Lantus to be at night instead of in the morning, so that they can cover that period of waning insulin with mealtime insulin at night. Did that answer?
Yeah. Okay. I mean, for as much as we can here, I think that's a pretty good answer.
It's like the 30,000-foot view.
Yeah. Let's see. Just trying to go in order here. I don't see Medtronic's products listed, I guess, on your slide. Does that mean they aren't the best option for CFRD? I have not had anybody that has had Medtronics who's been really happy with it. They also had a bunch of issues last year with their technology. So it's not, I guess, it's not a technology that I feel really confident in prescribing right now. It may come back around. I'm sure it will, but right now I would not, probably.
I mean, if you have it and it's working great for you, fantastic. Yes.
Let's see. Is it common for CF patients to have reactive hypoglycemia or insulin resistance? And if so, how likely is it to progress to CFRD? I think you
Okay,
might
those
have kind of
both
touched on this.
Yep, those are both CFRD. So reactive hypoglycemia is what happens once the first phase of insulin dies, essentially. And so you're not getting, so you eat and no insulin comes out, so you shoot straight up. And then the second phase of insulin hits, but it hits extremely, it's very robust and way more than your body needs because you've already started to come back down. And so then you go into reactive hypoglycemia. So that's really the first and second stage of CFRD. What was the other? Oh, resistance?
Insulin resistance, yeah.
So resistance can definitely happen with inflammation. It's, you know, anytime, I know with our son, like as soon as we start to see it climb and climb and climb for a couple days, we know that there's an infection coming. Your blood sugar is going to be your first predictor of a exacerbation. It's incredible that way. It's like the one silver lining of CFRD that allows you to get on things a little quicker. But the other part of that is that we will definitely see people now as body types are changing and we're seeing much more of our population overweight and even obese, that there are going to be more resistant tendencies and that there will be higher doses of insulin necessary based on body type.
Great. Someone is asking, how is the InPen different from the Dexcom?
Okay, so the InPen is really like how you're dosing the insulin. So you are putting the pen tip on the InPen and administering it through that. And the dose that you give yourself when you turn the dial speaks to your phone and keeps track of that and speaks to the Dexcom. So everything is in that app. So you do need to have, in order to get the best data, Dexcom and the InPen. But I have plenty of people that just have an InPen and no Dexcom and vice versa. But it is a wonderful, like kind of pseudo pump. Without
so just
being
to
touched.
clarify, the Dexcom is what we put on.
Yes.
That continually monitors your blood sugar.
Sorry. Yes.
Okay. No,
yes.
that's okay. Yeah. And then they can talk to each other that way.
Exactly.
Yeah. Super cool. Let's see. What is the ideal timing between insulin injection and eating carbs?
So that is very based on if you're on rapid insulin, ultra rapid, or regular insulin. So regular insulin is almost 45 minutes. And just regular insulin, rapid acting like Novolog is somewhere between 15 and 30 minutes. And obviously those with more insulin resistance are going to see longer periods of time prior to seeing a decline in their insulin or in their blood sugar. So if you think of the resistance component, your body isn't utilizing that insulin as quickly. And so therefore you're not going to see numbers change. And that really kind of helps you to understand where your resistance is. FIASP, which is an ultra rapid, is generally 3 to 5 minutes. However, I've had people that it's closer to 10, but it's definitely much quicker than Novolog, generally speaking. And there are some people, like people who have delayed gastric emptying, that FIASP is not a good fit for at all. It sounds like it would always be good, but people with delayed gastric emptying, we often dose postprandially rather than prior to eating. So FIASP will give them a low.
All right. Somebody liked this question, so I think we should clarify it. Can you use the pen along with a continuous glucose monitor?
Yes. Yes. So it's just a great duo. It's my favorite one.
Let's see.
And you can go on the InPen website if anybody's interested in that. It's like They're actually part of Medtronic now. They were just absorbed last fall by them. And so, and you can fill out like a form to have it go to your clinic and have that script written. It's super quick, and you just add your insurance, and then it'll go to your clinic and insurance. So
That's great.
if you're interested in it, yeah.
Okay. How does menopause affect a woman's sugars?
Yeah, super challenging. I feel like, so what we've noticed in CFRD, and obviously again, super personal for each person, but oftentimes, if you look at the trends of decline in health for women, it's starting at puberty, and the decline is pretty significant in the old graphs. And that was very tied to that, you have just a lot more hormones, which causes the resistance. And so we would see females have much less life expectancy. And it was always kind of like that downward trend during puberty. And that's often when females are diagnosed as well, is that kind of period where there's just a lot more stress to the pancreas to keep up.
And then
during that time.
would that be the same for menopause?
Right. So
we know
pregnancy, yeah, I know, right? We don't know much. So pregnancy, we see like a lot of resistance. And if you're pregnant or considering getting pregnant, I really, really highly recommend you work with a CF endocrinologist that's very well versed in it, because it is very challenging. With a pump, it's much easier. And then on the other end of that, as you see waning hormones, it's going to be the same as like after an exacerbation. People say, oh, I went into the hospital and I had like intermittent CFRD. And we can say, if you have CFRD in the hospital, you have CFRD. That's just what it is. And it's kind of that idea that as soon as those hormones are going to slow down, I would be watching basal really closely. And same with Trikafta, as many of you probably experienced, that when as soon as that infection and inflammation started lowering, you started seeing very low numbers that you weren't used to. And that's really just kind of based on that resistance component. So anytime you have hormone changes, I would be really, really cautious with following your fasting blood sugars, backing off if you need to.
We have two questions about sleeping and sweating too much. Mm-hmm. And is that related to CFRD that you've seen?
I've heard that a lot. Definitely untreated, your body is just absolutely working a lot harder. So for someone who is having excessive sweating at any time or excessive thirst at any time, I would really highly recommend getting a trial of the Dexcom, which your clinic should be able to do. And you can just wear it for 2 weeks and get the real numbers, and OGTT may miss you. And so it's really important to really, and all of our, finger prick equipment is just, it just can have a very large gap in what your actual blood sugar is. So you have to be really cautious to get a meter that's been really well tested. So the Dexcom, if you're having nighttime sweats, I think would be a really great step.
Okay.
Or Libre, but they're a little falsely low sometimes.
Can you speak to time in range? Assuming this must be pump related.
I would say, I would love to know more about if they're on, like, what the question is there specifically. I am definitely not that. So I think that we look at this very black and white and we think like, oh, my A1C is 5. But if it's 5 because you're at 220 sometimes and you're at 60 sometimes, like that 5 is is going to be falsely reassuring to you. So for me, as a diabetes educator, like I really look at people's standard deviation. So if your insulin rate is correct and you take your blood sugar before you eat and you take your blood sugar an hour after, there shouldn't be more than 30-point deviation. So the deviation is what causes those long-term complications. So when your blood sugar is at 100, your blood is about the consistency of water. When it's at 250, it's getting close to the consistency of ketchup. So your veins and vessels are expanding so much, mostly your vessels, to be able to handle that. And the viscosity that just kind of keeps changing. And that's really what causes all the eye damage and kidney damage and neuropathy. And so for me, time and range is relative to what the high and the low was that got you to that range. So yeah, much more cautious about the highs and the lows.
Question.
Yeah.
Let's see here. Someone is asking, is Humalog the same as Novolog? And we also had another question that was, what is basal insulin and why is it important? So I don't know if you can.
Yes,
somehow.
Humalog and Novolog, yes, and same, and usually work pretty well in most people. Like it's usually just based on what insurance will cover. Basal insulin is essentially just trying to pull down your overall blood sugar. So I think of it as like if you're kind of resting up at the peak of a mountain, it's trying to bring you down to the valley so that you're starting there versus starting at the peak of the mountain. And so but its job is to cover the hepatic glucose. So the glucose that's stored in the liver that is, that the body uses anytime that there's stress, hormones, like waking up in the morning, that's all hepatic glucose. So really all it's doing is just keeping you as level as possible. And then you add the bolus insulin onto that when you add in any sugar, carbohydrates, or anything. Yeah.
I know we're getting close to time, but I think we can squeeze one or two of these questions in if you don't mind.
Yeah.
There's one I just saw, kind of just moved. I'm sorry. Okay. Why is excessive need for sleep a symptom of CFRD?
Well, your body, your body is just working so hard, and there's so much sugar cycling through it all the time because your cells can't absorb that. And so I'm trying to remember, I feel like, the quote of one person was really intense, and it was just really that he thought all of his life, like it was CF that made him so tired. And that as soon as he got the CFRD under control, that he felt like he had a totally different life ahead of him. So just kind of taking into account that lethargy is part of diabetes. And not to say like, obviously CF makes you tired too, but but there's something that
decipher.
We can manipulate things a little bit more with diabetes than we can with CF.
Okay, the last question. Do you like the InPen better than a tandem pump?
Oh, geez. I think that they all serve such different purposes. And I like, for someone who, like our son, who has had a feeding tube and, been on IVs so many times, like the idea of having a pump is absolutely out of the question for him. And so I have complete respect for that. I think that the Omnipod has a lot of benefit because it's a little bit bigger than the Dexcom, but it's tubeless. But the tandem pump, obviously the technology there is pretty outstanding in keeping people in range in that kind of basal IQ versus the control IQ. Both those technologies are incredible. So I think that they all are very, very specific to what your goals are. I think that hands down, if you want to have incredible control, the Tandem pump is amazing. And I think it definitely has the best technology right now. If you understand diabetes pretty well, and you know yourself pretty well, then InPen and Dexcom allow you to be a little bit less connected. Is that fair enough?
I think that's fair enough. I'm a big fan of the Tandem, but
yes.
you know, that meant love. Well, thank you so much. You know, it's amazing information and so important. And if you want to share, or at least tell your personal coaching again, if you're interested, and you know, we'll let everyone know that they can definitely go to the Attain Health Foundation for the self-paced class.
Absolutely.
Which is great.
Yeah. And then, if anybody's interested in just like coaching, it's just porcocoaching.com. Pretty easy. And, but and then the Attain Health site has the self-paced program, and I'll have you send out that, like, essentially the PowerPoint with the slides.
That'd be great.
And if people are interested in the syllabus for the program, I'm happy to send that out as well. So whatever interest there is there.
Thank you so much.
Absolutely.
It's been a wonderful hour seeing you and catching up again, and hearing all the reminders and refreshers for myself too. Appreciate it. Let's see. I also want to send another thank you out to our sponsors who helped us bring this event to life tonight. So thank you, Vertex, Beatrice, Gilead Science, and Nestle Health Science. And also a big thank you to everyone who tuned in tonight. We hope you found this information helpful. And the recording will be available tomorrow on the Take a Breather website at www.takeabreatherfromcf.org. And I hope you all have a good night and stay safe and stay well. So, thanks again, Kat. Always a pleasure.
You too, darling. Have a great night.
You too. Bye.
Bye.